cancer should never be a surprise. Cancer is treatable at stage 1, right? We're talking maybe cure versus 5-year survival rates in chemotherapy and radiation. So what are some of the cancers that you can see with an MRI that traditionally were not found until they were symptomatic?
Yeah, so we can see most any solid tumor at a localized stage. Mainly non-solid tumors are hematological cancers, so things like leukemias. We actually do see them, but we see them when we see marrow expansion in the legs, and ideally you want to catch it earlier than that with a blood test. So what's great is anything that's not a solid tumor, there are tests for this actually that you can do. But with solid tumors, there aren't that many. So we have mammography for women, typically 40 years plus. You have colonoscopy for folks, and the guidelines are changing on this all the time. You have a PSA test, which is a pretty inadequate test for men. It's a test for prostate cancer. And not surprisingly, only 14% of all of the cancers that are ultimately diagnosed are diagnosed through those standard of care screening tests. So if your cancer isn't one of those 14% of cancers, when is it going to be diagnosed? And you can imagine that cancer is already usually progressed to say a stage 3 or stage 4.
Andrew, I'd like to welcome you to the Extend podcast and just tell you how much I appreciate you coming here today. I know you're an extremely busy guy. You're running a massive company, and it's just such a pleasure to have you. Thank you for joining me.
No, Darshan, it's great to be here. I'm excited to talk about what we do, the world of whole body MRI.
Yeah, and so, I have a lot of knowledge about that. I've known you for a while now, and I have a lot of knowledge just from using the MRI services that you provide at Prenuvo with our clinic at Next Health. And so part of what we do when we have an executive physical come through is everyone gets a full body MRI. So as you know, I'm a big believer in full body MRI. And I was really looking forward to this episode, not just to dive into the science about it, but also to really get my audience's head wrapped around what is the current status of full body MRI and why is it becoming more and more important in our talk about health and longevity, right? I think you and I both mentioned, well, I want to ask you actually, what is the biggest misconception people have about services like full body MRI?
Well, there's many, right?
Yeah.
I mean, I think the first one, frankly, is that 20 or 30 years ago, you'll recall you could go to a shopping mall and get a whole body CT scan that was screened for cancer and disease. So, a lot of people confuse the two, CT and MRI. And for many reasons, that was not a great imaging modality for looking for cancer. And it was, most physicians discouraged it. The FDA got involved. And in some ways, it sort of poisoned a little bit the impression that people had about whole body screening. Right. The second misconception that people have, which is rooted in the idea that, hey, MRIs have been around for 30 years. They're sort of like cell phones. I mean, I think my first cell phone I had maybe 30 years ago. And my first cell phone was a Nokia thing with a little tiny screen. And it would take little VGA pictures. And my iPhone 15 today also takes pictures, but those are almost like two different classes of product. Some hospitals out there are still operating MRI machines that are 30 years old. I know. Partly because they're so heavy and expensive, and they put them in the middle of the hospital and they build everything out around it. You almost have to shut down the hospital in order to actually upgrade one of those pieces of hardware. So MRI has come a long way in the last 30 years. The hardware's got better and better. The sequences that we run on this hardware, so these are the sounds that you hear when you're lying in the machine if you've done an MRI. Those are taking pictures, filtering today for different tissue types. So rather than just a black and white picture of what's inside, we're now able to filter for blood, proteinaceous tissue, fat, fluid, and really importantly, a really, really powerful sequence that filters for hardness inside the body. And all cancers are, well, not everything that you feel inside your body that's hard is a cancer, but almost all cancers are more solid than the surrounding tissue. So this is really helpful for lesion discrimination. And then finally, there's the radiologists involved. Most radiologists are spending the majority of the day reading knees and shoulders and, an occasional spine or a brain MRI. There's just not a lot of people out there that are really sort of skilled at reading whole body MRI. So I think that the misconception is, all MRI screening services are the same. All of the research that we've done on screening with MRI is sort of equivalent it's very, very hardware, software, and radiologist dependent. And when we go out and educate folks, that's sort of the education that we're trying to provide to radiologists, to physicians, and to consumers.
Yeah, I feel like this is a really important episode, not just for the listeners of the podcast and consumers, but also for doctors that are listening, because I also had many of the same misconceptions. I was trained in medicine 25 years ago, and I had access to one of those MRIs in the middle of the hospital.
Yeah.
I remember it was one of my least favorite things to do was to go with my patient to the MRI scanner, because you'd literally be sitting in there forever waiting for an MRI to get done. And now, I've done the full body MRI myself, and it's a completely different experience. And so I want to dive into all 5 of those things that you talked about. But first, I think it's important that we talk a little bit about just the full body MRI process. So let's talk about someone says, I want to get a full body MRI for screening purposes.
Yeah.
And I think the mindset is really wrapped around finding cancers that you wouldn't normally find, because obviously everyone's fearful of cancer. A lot of people don't know they have cancer until they're symptomatic. But there's so much more that the full body MRI tells us about. And I'd love to kind of dive into just a spectrum of things that we are looking for, that we can find, that we can see in someone's anatomy when we obtain a full body MRI scan.
Yeah, I mean, it's a great observation. So as you know from your practice, MRI can see the soft tissue very well. Right. And so we can see pretty much any physiological disease that you might have. And we can often see it much earlier than it might present sort of clinically in a symptomatic patient.
I would say like symptoms are the last thing most diseases will present with, right? And so having tools like, first of all, blood tests and biomarkers, we can see diabetes, for example, 20 years before it develops. Now with the MRI, we have also a whole host of chronic diseases we can also find.
Yeah, and to be honest, we're actually learning through doing so many imaging of patients that are quote unquote normal that we're starting to learn and identify biomarkers of some of these diseases that would later be called chronic diseases way earlier than we thought that we might be able to. And we're seeing this for metabolic disease. We're seeing this for musculoskeletal degeneration. We're seeing this for neuro degeneration. And it'd be great to dive into each of these, because I think it's just really fascinating findings that we sort of are able to see by virtue of the fact that we're screening patients that range from 20-year-olds to 100-year-olds, that range from people that are very healthy to people that might have quite a bit of disease burden. And that spectrum enables us to sort of really understand how disease progresses.
Yeah, no, it's a fantastic topic to dive into. But, since cancer is like one of the main reasons people are looking to get a preventative MRI. Let's start with cancer. You had mentioned that you have this sequence that you're running. And I want people to understand that the MRI machine is a piece of hardware, and then you have software that's interpreting all of the signals that are coming back from the MRI. And you can see things like blood vessels. You can now see hardness, which is important, because as a surgeon, when I go into someone's body and I open them up, you can't see what's going on inside the liver, but you can feel a hard tumor in the liver.
Correct. And
to be able to see that with an MRI, I'm doing air quotes for people that are listening, is a game changer. And so let's talk about cancers. And, I think it's good to look at it from perspective of cancer should never be a surprise. The main message I have for my patients is cancer is treatable at stage 1, right? We're talking maybe cure versus 5-year survival rates in chemotherapy and radiation. So what are some of the cancers that you can see with an MRI that traditionally were not found until they were symptomatic?
Yeah, so we can see most any solid tumor at a localized stage, so stage 1.
Can you define that, by the way, solid tumor versus non-solid tumor?
So, I can maybe define it by what's not a solid tumor.
Yes, let's talk about that.
So mainly non-solid tumors are hematological tumors. So things like, cancers. So things like leukemias. Yeah. We actually do see them, but we see them when we see marrow expansion in the legs. And ideally, you want to catch it earlier than that with a blood test. So what's great is anything that's not a solid tumor, you can, there are tests for this actually that you can do. But with solid tumors, there aren't that many. So we have really mammography for women, typically 40 years plus. You have colonoscopy for folks, and the guidelines are changing on this all the time. And then you have a PSA test, which is a pretty inadequate test for men to test for prostate cancer. And not surprisingly, only 14% of all of the cancers that are ultimately diagnosed are diagnosed through those standard of care screening tests. So if your cancer isn't one of those 14% of cancers, when is it going to be diagnosed? And that's typically incidentally, or you're lucky, you maybe feel something, or you have a sort of like a pain of some sort. In the UK, about half of all the cancers are diagnosed in an acute setting in a hospital. And you can imagine that cancer is already usually progressed to, say, a stage 3 or stage 4 cancer by that stage.
Yeah. And so having the ability to diagnose tumors potentially at stage 1 is a game changer. Unfortunately, insurance in the United States does not cover this screening modality. I don't know why. I'm hoping things will change, because obviously cancer is not just curable when it's diagnosed at an earlier stage. It's also a lot cheaper, right, to deal with these cancers.
Yeah, and it's sort of, look, every cancer is different.
Yeah.
So it's sort of hard to generalize. But there have been certain studies. There was a study, I believe, out of Hopkins about 5 or 6 years ago where they looked at pancreatic cancers in people that had died of it. And they were able to sort of genotype those pancreatic cancers and get a sense of how long they'd been in the body for.
Oh, wow.
And it turned out that they had been in the body on average for something like 8 years.
My goodness.
So also when we think about stages of cancer, we tend to think of it as, it spends as much time in stage 1 as stage 2, as stage 3, as stage 4, but that's not necessarily true. And in fact, at Prenuvo, when we find cancer, more than 90% of the cancers we find are stage 1, which leads us to believe that cancers are spending the majority of their time actually at stage 1 and that, it progresses through those later stages relatively quickly. So that sort of window of detection is actually quite broad. And, that doing these scans maybe every couple of years, allows someone a pretty high probability of, never being diagnosed, ideally, with a cancer at an advanced stage.
Yeah. I always say, Steve Jobs had access to a full body MRI. He might still be alive today. What a difference the world would be.
Yeah, well, with pancreatic cancer, I mean, we've caught a number of localized stage 1 pancreatic cancers, and we send them to surgeons, to specialists here in Los Angeles or around the country. And, every so often we get a message back saying, hey, it's incredible that you sent us this cancer. It's like a real privilege to be able to actually have a pancreatic cancer I can operate on.
Exactly, yeah.
Yeah.
The surgery for pancreatic cancer is usually a Whipple surgery. Most of those are aborted when you go in because the cancer's already spread to blood vessels and surrounding tissues that you cannot even attempt to remove it without killing the patient. So it's such a blessing to find a pancreatic tumor that can actually be removed in the operating room. What are some of the other tumors that you can detect with the full body MRI?
Well, I'll give you a sense of maybe what we see sort of more routinely
great.
because there's no limit. There's hundreds of different types and subtypes of cancers. We see a lot of kidney cancer. In women, we see a lot of ovarian. By a lot, I mean we are catching ovarian cancer, and that's really a life-saving diagnosis because also typically caught when it's quite advanced. We find brain masses. And there's a lot of really interesting research. There's sort of 2 main categories of brain cancer. You have gliomas and glioblastomas. And everyone, for a long time, we considered them 2 separate types of cancers. And there's some more recent research suggesting that gliomas end up sort of migrating to glioblastomas. So, if we're able to find one of these as a glioma, there's a greater possibility that surgery can actually, resect that tumor. What else are we seeing? We see cancer in every organ.
Liver, bile duct, right?
Bile duct, intrahepatic tumors from time to time.
Sarcomas, I'm sure.
Sarcomas, yes. And we actually screen patients. We have quite a few patients come in that have genetic cancer predisposition syndromes. And sarcoma is quite a common cancer to get with those syndromes. We obviously see prostate cancer. We catch breast cancer. Sometimes in women that have had negative mammograms, in the recent past before coming in to get a scan. So it sort of runs the gamut of every organ, to be honest.
One of our patients that has spoken about this publicly, he he caught a glioma in one of your scans, and we were able to get him to a neurologist. And, like you said, a lot of gliomas turn into glioblastomas. And so it's good to have been able to diagnose that early. So I have personal experience with a patient that had exactly what you're talking about. So some of these cancers too, when you look at them at stage 1, I think a lot of people are really fearful of the diagnosis of cancer. And I hear this a lot, which is, well, if I have cancer, it's going to take me out anyway. So why would I want to know early?
Yeah. Well, it's I think the psychology of preventive health I find really fascinating.
Me too.
To be honest. And I sort of had this thought the other day. I don't know if this is going to be a very good analogy, but you've heard the expression, a child, an infant is never born racist. They sort of, they're taught it by the people around them or the institutions. I have a young child. If the child has a boo-boo, a Band-Aid or something, like every child will want to tell you what's wrong with them, And something happens between childhood and adult, and now we don't want to talk about it.
Right.
If we feel pain, we tell ourselves it'll be gone tomorrow. We're afraid. We're fearful of these. I mean, even today, I get a test every year, but before I go in, I'm a little bit nervous, right? It's a normal psychological response, and it's a response, I think, because of this reactive healthcare system that we sort of are exposed to, where you don't hear about all that many stage 1 cancer diagnoses. All you hear about are the really horrible stories of friends, family, neighbors, colleagues. And why on earth would you want to know? Why would you want to be diagnosed with anything if anything you imagine that you could be diagnosed with is going to be a horrible, life-changing event? And, I wish I could, if I had one desire, it would be to convince people that these new tests and comprehensive blood tests, like the different preventive health interventions that are available today, really make it possible for us to diagnose all types of diseases a lot earlier, and hopefully over time just change the relationship that we have with disease, from something scary to something that's sort of proactive. It's about maintaining our bodies. It's about lifestyle modification, not necessarily complex surgery. That's my dream.
Yeah, I agree with you. It's, everyone has a car that has a check engine light. And our body sometimes doesn't give us a check engine light until it's too late, until it's right about to break down. No one would see that check engine light and not do something about it that prevents something bad happening, where you potentially have to junk your car, right? Why do we do that with our bodies, with our biology? Why do we wait till everything is broken down before we decide to, look at our check engine lights?
And
right?
for those of us that spend a lot of time working in our heads, our bodies is the vehicle that drives our brain around.
Right.
So, you need a check engine light on that thing. Otherwise, your brain's not going to get places.
Yeah, it's an incredible time that we live, that this technology is now more available. I think it's a good time to talk about the aspects of incidentalomas, because this is another concern that people have with full body MRI or a lot of other tests that are done, blood tests, et cetera, that what if you find something, and most of the time we don't know what it is. We can't definitively say this is a cancer, right? And we have to do further testing. And this is a question I answer a lot for my patients about the whole aspect of incidentalomas, which is a medical word saying we found something, we don't know what it is, we need to do a workup now, right?
Yeah.
So let's talk a little bit about how you discuss this aspect of full body MRI.
Well, I have a couple of thoughts on it. The first is really, again, a lot of the misconceptions that people have about incidentalomas in whole body are informed by our experience doing CT screening. So in that CT screening world, CT, by the way, it's a spinning X-ray. So what an X-ray is good at? Looking at bones. So they don't have a lot of sort of contrast when it relates to looking at the solid tissue of the body, so that our organs where you tend to get cancers. And so, you would see a shadow in the liver, and then, this is the typical story. There'd be a shadow in someone's liver. You'd have to go and do a bunch of tests. Eventually, there'd be a biopsy. Back 20 years ago when they was doing those tests, the biopsies were actually more dangerous than they are today. Inevitably, if you do enough of these things, someone is going to actually die from the biopsy and not, and then the question that the medical community has is, well, are you saving more lives than you might be, harming by having all these sort of cascade of tests that might follow? With MRI today, with the multi-parametric MRI that we're using, so again, these are all these filters.
Can you define multi-parametric real quick before you?
Yeah. So we're able to. So when we take a photo, for example, I use photos, but I think of it like a camera, MRI. So we're taking these images of, let's say, your liver, and we actually image your liver 14 different ways. And some of those are different planes, so we can look at it from different directions, but we're filtering there for fat, for protein, for blood, for fluid. We're able to see air, and we're able to see hardness. And every type of lesion in the liver has a certain signature across all of these different photos that we're able to take. And they're all black and white, and this is what the radiologists are very good at. They'll say, well, there's high signal on this image, and it's low on this one, and I can't see it on this one, and it's high on this one. So the mental chart I have in my brain enables me to say, okay, that's a hemangioma, which is a benign finding. Probably about 20% of people have them. We don't need to do any more tests. If you have any amount of worry about this, we'll check in on it again next time. But these things tend to be stable for your entire life.
So with the MRI, these interdental findings, you can actually tell what they are with certainty.
You can much more precisely distinguish the things that are benign from the things that are concerning and potentially malignant.
Fantastic.
So the sort of, I don't really like the word incidental finding. We risk stratify everything that we see.
I see.
And so we rate everything on a scale from 1 to 5. 1 and 2 is you don't need to worry. 4 and 5 is increasing levels of concern. And 3 is sort of we're not sure. And in that third category, oftentimes there's kind of 2 reasons we're not sure. Most likely it's because something's very tiny. And in that case, most likely we can just check again when someone comes in for a subsequent scan. And if it hasn't changed, well, a lack of change favors something benign. If it has changed, we still saw it early enough that you can then go and get appropriate treatment or testing. And then for a much smaller proportion of findings that, in that third category, you need to send someone out to do contrast imaging. So that's the one thing that we don't do is we don't inject contrast when we do these scans because it's a heavy metal. It accumulates in the brain. You should, if you ever need an MRI or a CT with contrast, you should actually do it, in an acute setting, but we don't believe that's the right approach for screening.
Right, absolutely. That makes complete sense. So with findings with the MRI, you're much more certain about this risk stratification. I like the way you stratify from 1 to 5. And it gives clinicians like myself an idea of whether we need to go down the rabbit hole on this or not, right?
Right. Yeah. And to give you an idea, we followed a bunch of patients most recently. We're yet to publish this, but we will. And of those patients where there was a finding that was biopsied, about 50% of those patients, those biopsies came back positive for cancer. And to give a sense, I think the mammo positive biopsy rate is something like 20%. Right. So this modality and sort of the advances most recently have enabled us to be really good at that process of distinguishing between benign and concerning for malignancy lesions.
That's excellent.
Yeah.
As far as tumors go, just to be complete on this topic, because it's an important reason we use full body MRI. As far as tumors go, which tumors are kind of a blind spot for the MRI?
Sure. I would say probably, without a doubt, and it's unfortunate because it's probably the most common cancer, breast cancer is challenging on almost every imaging modality.
All imaging modalities, right?
For different reasons. Yeah. So mammogram is for younger women that have what's called dense breasts. This is typically women that are premenopausal. Mammogram is particularly bad. And in fact, most recently now in most states, if you do a mammogram, it's now mandated that the report says almost,
dense breasts, right?
You have dense breasts, so this is not going to be very accurate. Which is not particularly helpful for people, to be honest. In many states as well, they're legislating for breast MRI to be covered by insurance. That would be contrast-enhanced breast MRI. Oh, wow. And there are many physicians that recommend also patients do ultrasound. Yeah. So that's, I would say, like the one cancer where, were I a woman, and I was particularly concerned about this, I would be rotating modalities.
Absolutely.
I would do mammo, ultrasound, MRI, maybe in alternating years.
Right.
Yeah.
I agree with you. I did a lot of breast cancer surgery in my life as a surgeon, and a lot of times people have a mammogram and they get a false sense of security, and they would ignore the dense breast, because it wasn't really called out, and turned out they had a tumor for probably a long time. And so I think that's in a lot of these cases now too, with dense breasts on mammogram, we are getting an MRI of the breast as well, especially on the initial mammogram that's positive for dense breasts.
Well, the challenge though is, there's a whole bunch of folks that are now getting contrast-enhanced breast MRIs annually, and I think there needs to be a lot more work on non-contrast techniques.
Absolutely.
Or certainly non-metallic contrast agents, so that you don't have that side effect of the contrast agent accumulating in the cerebellum.
Yeah, absolutely. Do you think technology has a role to play with that? Utilizing artificial intelligence, for example, to delineate the non-contrast images and get better resolution?
I mean, for sure. Yeah. And we're working on AI that is already performing sort of equivalent to a radiologist level of performance in characterizing breast lesions. Probably initially, the models we're doing and models other folks are developing will be used almost like a second look. So rather than have one radiologist read a breast MRI or even a mammogram, they're doing the same things there. Typically, you'll get an actual radiologist and then an AI. And if they agree, everything's good. And if they disagree, then a second radiologist would actually then look at those images. And you have to imagine the combination of that sort of stage gate approach is going to lead to much more accurate imaging exams.
Absolutely.
And I think here, not just for cancer, but obviously for other conditions as well, as we are able to process more and more image data and build models around more and more diseases, the real promise is that AI can really help supercharge the radiology that any practice is doing.
Yeah, absolutely.
Yeah.
Back to the cancers that are kind of a blind spot for MRI. Besides breast cancer, there's some talk about lung cancer also being a blind spot. Is the technology advanced with the MRI where that's getting better?
It has, and it's sort of a hard one to talk about because there's so much evidence, and there's much evidence behind low-dose CT screening of the lung. And there just hasn't been that many people that have studied the use of non-contrast MRI for lung cancer screening. There's a few researchers in Japan, and Japan is a country where there were a lot of former smokers, where they're starting to look at using MRI as an alternative to CT. For sure, an MRI is not going to find very, very tiny nodules that might be sort of pre-cancer or very early cancer. So with an MRI, we're mainly looking for nodules that are more than a centimeter in size.
Okay.
The good news is that MRI doesn't see, there's a nodule called a granuloma. And this is, well, I'll defer to the doctor here, but this is sort of a typically something that's invaded the lung that the body has basically built a calcification around.
Yes, exactly.
And once it's typically in the southern part of the US, it's like a fungal infection. And
also here in California in the Central Valley.
Yeah. And so these things light up on a CT.
Yeah.
And when they do, there's a process of following them up over 3 months, 6 months, 12 months to make sure that they're stable and not something else. Most of those we don't see on MRI. So those sort of like benign granulomas are almost invisible. And that is, in some ways creates less noise in the image that we're taking on MRI. But I think, it's pretty clear standard care screening, at least for smokers, are to use low-dose CT.
Right.
And meanwhile, we'll keep exploring and collecting evidence for non-contrast MRI, and particularly because we are having a lot of patients that are not former smokers and so don't have access to the CT screening that's offered to people that have smoked however many pack years, that is required for insurance to cover it.
Yeah, and it's that's another travesty is like insurance doesn't cover screening CAT scans, but half the tumors of the lung occur in non-smokers now. And so you're missing a lot of those. And so it's nice to know that the full body MRI can also pick up some of those as well, right?
Absolutely. And I would say maybe probably because our customer base skews towards people maybe that didn't spend a lot of time smoking in their lifetime, I would say we catch more lung cancer in people that are non-smokers than we do in smokers.
Wow.
And young women are sort of 3 times more likely than young male non-smokers to actually be diagnosed with lung cancer. And we don't quite know why there's this gender difference. But we see that in our data as well. We will, thankfully not that often, but when we do find lung cancer, it tends to be in a woman between 35 and 45 who never smoked. Yeah.
That's incredible. I did not know that. That's mind-blowing to hear that, actually. And so especially important, I think, for many reasons, for men and women to consider these screening modalities, because you can catch something like a lung cancer much sooner than you will ever get symptoms, especially if you're young, right? And then probably you can do something about it.
Yeah. It's, lung cancer is not one of those cancers you want to be diagnosed with.
Absolutely.
But we are, and when you're in this business, you start to build a hierarchy of which are the better cancers and which are the worst cancers, unfortunately.
Sadly is true. Yes, you do.
But we have found them, and we've had patients that, have just had their cancer resected.
Yeah, absolutely.
And it's been a life-saving diagnosis.
Yeah, another surgery I used to do is remove lung cancer. So let's talk about solid or hollow organ tumors, colon cancers, esophageal cancers. How does MRI rank now with diagnosing some of those?
So with colon cancer, we find it. We will not find it as early as a colonoscopy.
Right.
We don't have the benefit of having the bowel cleared out.
Yeah.
We won't find polyps, which is obviously a
precancer.
And the benefit of colonoscopy is it's not only looking for colon cancer, but it can remove those polyps in this, at the same time. We diagnose esophageal cancer from time to time, but it's not going to be as accurate as a scope.
Sure.
And I would say the same thing about stomach cancer. So, if I was to rate us on a scale of sort of 1 to 3, where 3 is we're great and sort of 1 is we're not great, we're probably a 2 on most of those.
Yeah.
But thankfully there are other modalities. And those cancers are more likely to be symptomatic, at an earlier sign if patients are paying attention.
Yes, absolutely. And also with especially colon cancer, you can even do home FIT testing, which is blood testing on your stool, and that can give you some indication. However, none of it replaced colonoscopy, which is
I still get a colonoscopy every 5 years. Yeah.
Yeah. And I think what's important about cancer for people to realize right now is that the rate of cancer is going up. It's not just rate of cancer diagnosis. Almost all cancers, we're diagnosing more of them.
Yeah.
For whatever reason, it might be the environment we live in,
The food we eat, potentially.
The food we eat, absolutely, the air we breathe, all of these cancers, more and more people are getting them. And I just read a statistic that's scary, which is half of all people now will be diagnosed with cancer in their lifetime. It's some kind of cancer.
Yeah.
Literally 50% of people will be diagnosed. And so the sooner we find these things, the better. And so I think, using the combination of modalities, the traditional testing modalities and adding to it now full body MRIs, I think is going to become more and more important.
Well, it also gives you a lot more options, not just treatment options, but there's an option that's worth talking about, which is watchful waiting. Mm-hmm. And we have patients now that have been diagnosed with prostate cancer, and they come in every 6 months, and they just want to make sure that that's stable. Mm-hmm. And I think, we're going to see more and more of that. We also find a decent number of kidney cancers, and there's sort of a growing body of, evidence that those can
be watched,
be relatively slow growing and maybe watched over time. So I think we never really had these options because we only ever caught things at an advanced stage. And when you start catching them earlier, you can start maybe thinking about different ways of managing those conditions.
Yeah, absolutely.
And talk about what is it like for a man to have their prostate removed.
Yeah, it's really tough. Yeah, I think there's a lot of controversy around prostate cancer, right? Because it's you almost, for many men, diagnosing it later in your age, maybe you get diagnosed 65, 70, there's always a lot of controversy about whether you want to have it removed or not have it removed, because many men will die with prostate cancer, not from it.
Correct.
Right?
Yeah.
And so, but I do agree that having the option, depending, especially at a younger age, is monumentally different than anything that's ever happened before.
Well, and there's a lot of physicians even that will point to prostate cancer and say, well, the problem with prostate MRI and by extension whole body MRI, that as sequences of the prostate are the same as a dedicated prostate MRI, is that you might find a lot of low-grade prostate cancer. So, using the Gleason scale, these are like Gleason 6 potential lesions, and they may never advance to something that's like requires treatment. But that's what watchful waiting's for. So, two things really need to happen to arrive at sort of the healthcare system that I would like to have. One is we diagnose things early, and two, we use the fact that we diagnose things early to change, to maybe reconsider the way that we might actually approach the management of some of these conditions.
Right.
And we do our best to inform patients when we diagnose anything about what we think you should do. And that's pretty unusual for radiology because typically they leave that to the physician.
Yeah.
But the concern we have is, we don't want to have an unnecessary cascade of tests in that reactive healthcare system. So we do our best to inform the patient and inform their physician where follow-up is required and where follow-up we don't believe is required.
Right.
Yeah.
I think, that's when I talk to other physicians that call me sometimes that ask me, like, why'd you get a full body MRI in this patient? It's a conversation I often have, which is the physician who is not, I would say, in favor of these modalities because they have a different mindset or they're maybe educated years ago. Is their mindset is kind of wrapped around like, now we have all these unnecessary tests we're doing and we're going to remove this tumor unnecessarily. And really the conversation I have with them is we need to change how we're treating these tumors when we diagnose them early, not ignoring them just as a blanket statement, right?
Yeah, and I don't know how self-interested, some of the sort of cascade of testing is, because I think one thing that distinguishes our business, Prenuvo, from other people doing whole body MRI and the health system sort of writ large is that we only do the screening. Yeah. We don't do the downstream diagnostic tests. So there's no upside in us, in sort of over-diagnosing anything. Sure. So I wonder sometimes, if somebody's doing a whole body scan in a regular imaging facility that would also benefit from doing a whole bunch of other follow-up tests, I wonder if that somehow might influence sort of the way that some of the things are called by the practice. And, I've had personal experience where I spent a night in hospital, in a large health system. And when I got my bill, the number of things that they tested me for that they could, I was tested at one point. I had a hospital with some chest pain and I got tested for like 20 different drugs. Illegal drugs, none of which I'd really even understood what they were, right. But every one of those tests was $500.
Yeah.
So, maybe we should also look at why there is this big cascade of testing that's happening out there in the hospital and health system.
I mean, you touched on something that is a huge rabbit hole that I go down all the time. Is the incentives are so misaligned. Is why I got out of traditional medicine anyhow. To begin with, is just physicians are encouraged to cover CYA, we call it, cover your bleep, right? And so you order everything, and that doesn't benefit the physician except to potentially not get sued. But there is an entire system of billing in hospitals and laboratories and that really do benefit from the tests that you ordered. And so it's so backward and so messed up. And that's why what I appreciate about what you're doing, what I'm doing, is it's outside of this system. There's no insurance billing that can be padded for the additional testing and et cetera.
Although, we hire radiologists
of course.
Were working before they worked with us in that system. Right. And so when we go through a process of training folks, and even when we get together as a clinical practice and decide how we want to call things and we try and standardize as much as possible, I mean, we have spent a lot of time sort of trying to eliminate some of the imprecise language that's used. A classic one is, hey, something in the liver, most likely benign, correlate clinically.
Yeah.
And we're like, well, what? And I will look at that and I say, well, what does that mean?
Yes.
Correlate clinically, how, with what?
Yeah, exactly.
And if so, what do you do?
Right.
And because you give that back to someone else, like a primary care physician, and out of abundance of caution, they're going to order more tests.
Absolutely, yeah. And they'll refer you to hepatologists.
And oftentimes, even the radiologist, an unfortunate aspect of the U.S. health system is there's a lot of litigation.
Right.
And a lot of physicians are doing these things out of a belief that it's going to make them
insulate them from lawsuits.
Insulate them. And it's not always the case,
Right.
Being imprecise doesn't inoculate you from a lawsuit. And so some part of it is just trying to educate folks that, no, we want to obviously as accurately as possible describe what we're seeing, but then be as precise as we can about what we think you should do next.
No, I like that a lot. Let's just to be complete on the cancer topic, because I want the listeners of this podcast to understand like where this fits in and where it doesn't fit in. And so in the future, when this becomes more available to everybody, I do believe it will become part of standard screening for people. You're part of the driving force to make this more accessible for people, which I appreciate. However, it does not replace, at this moment,
Correct.
certain modalities, such as mammograms, such as colonoscopies. Skin cancer screening, for example, also is extremely important. So have your significant other make sure they're looking at your skin and educate yourself on what skin cancer looks like. If you're not, most people never see a dermatologist to watch for these things. So I think it's important for people to know what skin cancer looks like. But other than that, we don't really have many other modalities. And so this is a massive additive to cancer screenings, especially at an age that humans are living with an increased risk of cancer incidence and at an earlier age as well. Not just more cancers, but even at an earlier age. So I think it's an important part of that whole puzzle.
Well, and also just to emphasize, we think that we understand this modality MRI better than anyone else. So we are pushing this technology to the limits.
Yes.
In fact, when before we started, you could get a whole body scan at a typical sort of academic institution, and it was offered to people with cancer predisposition syndromes, and it would take 3 or 4 hours. And we knew that would never work. So we needed to acquire, custom built hardware. We need to work on those acquisition protocols. We need to use AI to accelerate where possible. And obviously had to work on the radiology. And now we have an exam that's 45 minutes.
Yeah.
We think it's the best. It gives you the widest coverage that you can get in a whole body scan. It's not a perfect test for everything. Right. And for any one thing, like a colon cancer, or skin cancer and things like this, there are going to be other tests.
Yes.
But if you want to spend an hour to get on top of your health and to sort of, do the best check possible out there, I think is something that people might want to consider.
Yeah, I agree with you completely. And this is a good time also to maybe talk about the advancement in technology around MRI, because when I trained, MRI would take a long time. It was very uncomfortable, very tiny tube for you to sit in. The MRI experience was not a good one. 20 years ago, it would take hours. If you're claustrophobic, it was very difficult. And even what you could see was nowhere near what you can see now. So I think especially even over the last 5 or 6 years, there have been massive advancements, and you've incorporated them into Prenuvo, and you've actually led a lot of the advancements. So I'd love for you to talk about kind of how it's changed and what the experience is now and what we can see now versus even 5 years ago.
Well, you know what the biggest one is actually?
Yeah.
It's got nothing to do with technology. It's that we're looking at the entire body instead of one organ.
Right.
So, if you go and get a liver MRI, it might take 30 minutes. Right. We're taking all of, pretty much the same set of sequences that you might get if you're doing a liver MRI. Now we have hardware and software that makes it faster. So maybe we're doing it twice as fast. But in those same images that we're taking of your liver, we're also looking at your spine. Yeah. We're getting an axial view of the spine. And so going to get a single body part MRI scan, insurance paid at a UCLA or it can cost $2,000-$3,000. Yeah. Or some institutions charge $15,000, and you're, because you have insurance, you're lucky. Your copay is only $3,000. And we have patients come to us and say, hey, I was just going to get an MRI of my back, and it was going to cost $2,000. I may as well just come and pay a couple $100 more and do the entire thing. Mm-hmm. So there's like tremendous economies looking at everything at the same time. So rather than just doing one exam for $2,000 looking at one organ, we look at everything. Mm-hmm. So sort of the cost per organ is maybe $30.
Yeah.
So we're screening for pancreatic cancer for $30. We're screening for kidney cancer for $30. Screening for ovarian cancer for $30. So you sort of add all this up, and that's like where most of the economies come from, is by just looking at everything at the same time. It also makes for a more accurate diagnosis because our bodies are not like, we're not like a bag with a collection of organs inside it. I mean, our bodies are a system. Yeah. And we can learn a lot about, for example, our cardiovascular system by looking at our brains, or looking at our lower legs, or looking at the lungs. So, or we can learn a lot about even staging cancers or risk stratifying cancer. If we see a lesion in the adrenals, that's sort of indeterminate, but we don't see a primary lung cancer, most likely it's benign because the likelihood of getting a primary adrenal tumor is very, very, very low. There's this tremendous yield by looking at everything at the same time. Yeah. But also every year the hardware gets a little bit better. Mm-hmm. The machines are able to run a lot faster. Mm-hmm. And we're able to do a lot more with a relatively inexpensive machine. And that's bringing down the cost for everyone.
Right.
And when we started this, our goal was, those scans that you would get at these primary, these big tertiary institutions, the insurance would pay $50,000, $75,000, $100,000 for these. And we said, hey, we want to make something that we think is going to be accessible to as many people as possible. We would like it to be cheaper. We want to make it cheaper. But, around $1,000 for cancer screening or $2,500 for looking for everything in the body, there's a lot of people that can put money aside to do that, people that care about their health or for which their health is important for them. Sure. So that was a big part of sort of democratizing this and making it available for more folks.
Yeah, no, I think the technology advancements are on the hardware front and the software front, Correct. Which is really important to realize too, that you guys are doing a lot of work to make the scans faster. I want people to understand this concept of sequences that you've mentioned a few times. So, it used to be, and this is still done in many places that are not doing what you're doing, is you go in for a screening MRI and they're actually doing the cuts farther apart. Mm-hmm. So you're missing tumors potentially that are less than a centimeter or less than a full centimeter because the sequences are so far apart sometimes. And they're doing that because they don't have the advanced software to do these MRIs faster. Because if they're trying to get the same sequences in a traditional MRI of the liver Correct. Or the pancreas or the prostate like you guys are doing, it would take them forever to do it, right? And so you're saying that your sequences of the prostate of these organs are similar to...
Yeah, so this is kind of like this is the biggest misconception. So the biggest clinical study that have been done on whole body MRI, or the biggest clinical cohort was the UK Biobank study that happened over the last 10 years. Yeah. I think they did 10,000. I did MRIs on 10,000 people. They did a sequence that was called Dixon. Now we do Dixon in our in our protocol. It takes 1.5 minutes on our hardware with our software.
Incredible.
I think probably it took like 10 or 15 minutes there.
Yeah.
That's all they
that's all they did.
They didn't really do very much more than that. And you might see big, that might help you identify some abnormalities, but wouldn't help you characterize what you're seeing. And the abnormalities that you could see would typically be quite big. So when we think about MRI, we use a concept called voxels, and these are like 3-dimensional pixels. So we chop up the body 3-dimensionally, and how many pixels are we taking? What's the resolution of the images that we're taking? So some of those non-diagnostic quality whole body studies maybe took about 100 million voxels. Mm-hmm. a Prenuvo study has 1.3 billion voxels. So, it's the difference between sort of a television resolution sort of 20 years ago and sort of the 4K that you have today. You have better resolution, you're going to see more things. And those 1.3 billion voxels that we take are distributed across all those different types of sequences. So it adds this sort of dimensionality to the data that you didn't have on those early studies. We're not just seeing black and white, we're seeing sort of 8 or 9 dimensions of all these different tissue weightings that we're able to take.
Right.
And the combination of those is sort of the closest thing to like in vivo histology, like literally doing those biopsies that you used to do in the past. And then we mentioned that sequence that measures hardness. That's called diffusion weighted imaging.
Right.
Almost any MRI can do this, and it's routinely done in the prostate. But how big is a prostate? It's like this big.
Yeah, it's tiny.
And those exams take a long time. Yeah. So most hardware out there is not capable of doing this at the sort of quality we're able to do it in an acceptable amount of time across the entire body. And so people often ask me, well, such and such other company is doing a whole body scan. It only takes 20 minutes and yours is 40. I mean, I'm like, I could do a whole body scan in 2 minutes if I wanted to. The question is, what's the diagnostic yield of that scan? Right. And what makes it difficult for us and frustrating, it means that anyone that has an MRI machine can arguably say they can do a whole body scan.
And they do.
And they do. and that's the sort of these things we're talking about, voxels and sequences, and it's not very obvious to physicians even, let alone to consumers. Right. And so that's, I think, one of the big things that concerns me as, we've obviously created a lot of interest in this space. Other people will also, more and more folks will start doing these scans. And I'm a little bit concerned that, again, this modality is so qualitative. The difference between a highly medically accurate whole body scan and what you might get down at your corner shop imaging clinic is not going to be obvious, and it will sort of like perpetuate the idea that we shouldn't be doing screening.
Yeah. No, I agree with that. And so, what are some questions people can ask if they're out there looking for a full body MRI? Say your Prenuvo is not available in their town, and they are calling around, and someone says, "Yeah, sure, I'll do it." What are some questions they can ask that will give them an indication as to the quality of it? One of them being, are you doing diffusion weighted imaging on the entire scan? Right, that's one great question. Yeah. What are some others they can ask?
Well, I mean, look, I give you the questions. I don't think many people will be able to answer them, to be honest. I'd ask them how many voxels you're taking.
How many voxels?
Yeah.
Right.
I'd ask you how many diffusion voxels you're taking. Ask them the slice thickness. Are they taking 6, 8 millimeter slices? Or are they taking 3 or 4 millimeter slices? So
are your slices 3, 4 millimeters?
For us, it depends on the size of the person, to be honest, but they all tend to be between 3 and 5 millimeters.
Okay.
It also depends, mind you, on the part of the body too. So our goal has always been, we want to do a scan in 45 minutes. How do we slice and dice you?
Yeah.
In the most effective way so that we can be clinically diagnostic for as many things as possible.
Sure.
So what does that mean? That means the prostate's a tiny organ. Men are more quite likely to get prostate cancer. We want to take very, very tiny slices there. Right. We want to understand how people's brain volume is changing over time. Now, to accurately measure the volume of the brain, we have to take very, very tiny. Like the voxels there are 1 millimeter cubed. Wow. So very, very tiny. Your legs, I couldn't tell you what our resolution is, but it doesn't really matter so much because there's not a lot that you can get in your legs that's going to kill you. Right. So it's not a universal answer. It really depends on the organ, to be honest.
Right.
Yeah.
No, but that is great to know. The slice thickness, the number of voxels, no one's going to be able to answer that normally.
What sequences are you taking?
Exactly. Diffusion weighted imaging is a great question. Yeah. How long does it take? That should also be an indicator as to the scan itself. But I think also,
and what do they have on their website? I mean, is the company publishing research? Do they talk about the techniques they're using, or is it a menu of options next to a knee MRI or a shoulder MRI or a back MRI?
So when I did some calling around, I would often be told, well, we have a 3 Tesla MRI and they only have a 1.5 Tesla MRI. And you gave me an eloquent explanation of the differences between the Tesla power of the MRI. So maybe you can talk about that too a little bit.
Yeah, so that people understand, Tesla is essentially it's the strength of the magnet. And you have everything from a 0.2 Tesla open MRI to a 7 Tesla sort of research MRI. And as the Tesla strength goes up, the sort of the sensitivity to the signal that your body gives off in an MRI also goes up. So a 1.3 Tesla compared to a 1.5 Tesla actually has 2 times the signal to noise, which is promising and good. There's only 2 problems. The first problem is, although it has twice the signal, it has 4 times the heat. And so if you've ever lied inside an MRI, you start to it heats you up a little bit. And
like internally, you feel
a
getting
little,
heated up.
It's not,
internally,
I don't want people to feel like it's not like you feel like you're burning, but you feel a little bit, you start to feel a little bit warm.
Right.
And funnily enough, it totally depends on the person and their physiology. Some people more so than others. And all MRI machines that are regulated by the FDA, they have to ensure that they only put a certain number of heat in your body, a certain amount of heat. And if they try and put too much heat in, they usually shut down for a few minutes, which is horrible if you're trying to keep people to time. Yeah. So we plan our sequences in such a way that we kind of get close to that limit, but we don't go over. Now, if you're in a 3T machine, now you're getting twice the resolution, but 4 times the heat. So you have to image less, or you have to spend less time imaging a certain part of the body, so collect less signal in order to not trip those same sort of heat limits that the FDA sets. So that's the first problem. You really can't take advantage of it in the context of the whole body. You can for individual parts of the body. So a 3T is much better for the head or the prostate, for example. But because those are small parts of the body and you won't reach those heat limits. The second reason why 3T doesn't work as well as 1.5, which is what we use, is that it relates to the wavelength. So a 1.5T has a wavelength that is about the width of the body. A 3T has a wavelength that's about the width of the head. And so inside the body, you start to get interference. And that interference shows up as artifacts, and particularly artifacts around where air and fluid sort of touch each other in the body. So for the bowel, where most people have a certain amount of gas at any one point in time when we're imaging them, we start to get these artifacts, and it makes it much harder for us to see pathology inside the body itself. Yeah. So 3T, the parts where it gives you better resolution, we really can't take advantage of it, and we don't need it in a screening context. And in some parts of the body, it makes it worse. Yeah. But people love to say, I've got 3T, so it must be better. And the manufacturers also, a 3T costs a lot more, so they love to perpetuate the idea that it's a much better machine. But that's not the case for whole body. Sure.
Yeah. I've seen some 3T weighted, abdominal images, and you can even me, I'm not a radiologist, I can see the artifacts, and so it's much harder to see other organs that you're trying to look at as well.
Yeah. I mean, look, if we found a small 1 centimeter glioma in the brain, I'm almost certain our radiologist would say, hey, go get a contrast exam on a 3T machine at a great hospital we'd refer you to. But we can still see the glioma with a 1.5T.
Exactly. Yeah. And then you get it further evaluated by a 3T. But the point being, for screening, 1.5 is definitely the best technology that you want for the screening.
And, if we thought 3T was better, we would be using 3T.
Sure,
and anyone that's studied whole body screening or ran those clinical trials are using 1.5T.
Right. Yeah. Let's just talk real quickly about a couple of quick things. One is radiation. So compared to a CT scan, which has radiation.
100% less radiation with MRI.
100%. You go down to 0 radiation. What about, there's some people that are concerned about EMFs and other types of potential issues with the scanner itself and being exposed to a piece of technology for 45 minutes. Are there any concerns around those?
I mean, it depends on it's sort of like the individual sensitivity. There was a study I saw a while back, so I don't remember the exact numbers, but I think the amount of signal that we put in the body with these machines is equivalent to talking on a cell phone for like 5 or 7 hours or something like this. So either that should make you feel pretty comfortable about getting an MRI, or should make you feel pretty uncomfortable about talking all the time on the phone.
Exactly.
And so they're pretty safe. Every once in a while, someone gets some peripheral nerve stimulation, which is sort of, like a muscle contraction. But the second that you're out, it's done.
Yeah, and I've talked to neurologists about this, and they're not concerned about the EMFs. I've also, obviously, I think it's important to emphasize that there is no radiation, the typical radiation that you see with X-rays or CAT scans, right? No. Last thing is the comfort level of actually doing the procedure. So there's a few things there. One is claustrophobia. Secondly is the noise. What measures have you taken to help make this a more comfortable exam?
Yeah, so people may not realize, but I think the claustrophobic rate of a typical MRI is something like 10%. Mm-hmm. So there's 10% of people, they go in the tube and you're given a little ball to put in your hand, and that's sort of pulling the ripcord. So 10% of people pull a ripcord in a typical MRI.
Wow. That's a lot.
Yeah, it's a lot. Yeah. And so we were, and it's there, it happens for a combination of factors. The first is those old MRI machines were very claustrophobic. They were quite small. These new machines are actually quite big. I sort of think of it like the sensation is almost like lying in a sort of bunk bed. That's sort of how far away the wall of the machine is from your head. Whereas the sort of old-fashioned MRIs, it was right there. Obviously the fact that we've been able to speed up the scans has been really important for sort of like bringing down claustrophobic concerns. And the third thing is actually sort of related just to the anxiety that people have in having sort of any medical test. So what do we do there? So, well, and by the way, this is part of the reason why we just felt like we couldn't work with existing imaging clinics beyond the sort of technical reasons is the patient experience. And, so we wanted to build our own clinics and have nothing that would trigger that, do our best to not trigger that anxiety that most of us have. So we had no white walls and no one's wearing lab coats, and, we don't have fluorescent lighting, and, you go inside this machine and we have televisions in there so you can watch a video or a movie or a television show. You can listen to music. We have a binaural beats program that sort of cancel out the sound of the MRI itself. We're not as rushed as in a regular imaging setting. So if you're feeling anxious or nervous in a regular imaging clinic, oftentimes the tech is just trying to get you in and out as fast as possible so that you start irritating them, whereas we want to really make sure people feel comfortable. So all these things sort of combine. And then a small number of people actually take a sedative to come in. So if they've had an MRI before and they already felt like they were claustrophobic and they didn't want to have that trigger, they'll take a non-addictive sedative that one of our physicians will sort of recommend that they have prescribed. Yeah.
I think all of that is so important, Andrew, because the customer experience around getting the MRI at one of your centers, which I've been to one, I've done one myself, I've seen many patients. I now tell my patients that are fearful of getting an MRI because of claustrophobia or some of these other factors that give this one a try first, and they'll let you out if you feel like you can't handle it. I've never had a person hit the eject button on the Prenuvo scan. So I think that entire kind of wrap of the experience that you put on from the moment you walk in the door all the way up to getting in the scanner, it makes a huge difference. And, a lot of times people will show up to a full body MRI somewhere else and they're not given anything more than a set of headphones, right? And that cancel out the noise. And the distraction is important, right?
Yeah. And it's also made it possible that we can image folks that maybe don't routinely get access to imaging. So we have, every so often we have, for example, parents who bring in adult children that might be autistic or have Down syndrome or something like this, where they wouldn't ordinarily be able to tolerate that. And we have MRI safe chairs, and the parent will go into the room with the patient, and they'll be there to like calm them down or hold their hand or something like this. Like and I think that's kind of, we want to treat people the way that we would like to be treated, but don't feel like we're necessarily treated when we go and access health services. Yeah.
Right. No, that's so important. Wow. We talk about so many things and I have so many more questions for you. So I'd like to kind of move on now, if you don't mind,
for sure.
Beyond cancer. Let's talk about some of the other diagnostics, anatomical diagnostics that are important. And I'm thinking about aneurysms mainly. We have one patient that we diagnosed with a abdominal aortic aneurysm, another couple with actually brain aneurysms as well. So that's one other diagnosis that people don't usually get until it's too late, right?
Correct. Yeah.
And usually most people die of a ruptured abdominal or brain aneurysm. And finding them early is a game changer in your life because there are treatments that you can do that are now minimally invasive, things like coils and stents that you can put in that will literally save your life.
Yeah.
And I think these are rare conditions, but they're not so rare that it doesn't happen. I mean, we all hear on the news of actors and actresses that die of these type of things just because they make the headlines, but many people die of these things. I've been in the emergency room where someone comes in with a ruptured aneurysm and, at that point it's just palliative care, which is they're going to die,
Yeah.
So I would love for you to talk about other diagnostics that you get beyond cancer that this technology could be helpful with.
Yeah. Well, so in that category of life sort of threatening findings,
Mm-hmm.
I would say aneurysm is the other one. And aneurysm, it's not cancer, obviously, but it's the way I think about it is it's like a little balloon.
Mm-hmm.
And for anyone who's tried to blow up a balloon, it's hard to get started. But the bigger the balloon becomes, the easier it is to keep like making it bigger. And so, the sense is that, a lot of these aneurysms can be quite small for quite some time. And eventually they become big enough that maybe they require medical intervention. And so the window also for detection of aneurysms can be quite large. And we'll find aneurysms in folks that, the aneurysms are quite small. The patients don't necessarily have risk factors like blood pressure or they're not smokers. Mm-hmm. And oftentimes we'll also watch for weight those. Mm-hmm. So we might find a little small 3 millimeter cerebral aneurysm and we'll watch it and see if it changes. And if it approaches sort of 5+ millimeters, then you start to, the concern obviously probably has risen to a point where you might want to do something about it. Mm-hmm. But the technology is so, obviously these scans are able to see things so tiny these days that it's not impossible to see 2 or 3 millimeter aneurysms. And at that point, you're not still 100% certain that it is not just a congenital abnormality that the patient has and it's not an aneurysm. So, so oftentimes watchful waiting is the right thing to do.
Right.
Yeah.
Right.
And then sort of moving on from life-threatening conditions, and this is a category that I'm the most passionate about, to be honest. I sometimes feel like we actually have two products as a company. There's a product that people come in thinking they're buying, and there's a product that people stick around to continue to receive. So a lot of people, they first hear about us in the context of cancer or aneurysm. And they come in because, hell, I don't want to be the person that's diagnosed with something life-threatening late. But what I'm most excited about is the feedback that we can give people about how the way they're living their life and their genetics is impacting the underlying physiology of their bodies. Yeah. And I have so many examples, and I'm super passionate about this. We never look inside until we're diagnosed with something chronic. And by the time something is chronic, typically the only interventions that are, possibly helpful and oftentimes not are medical interventions. And when we diagnose things early, we have the possibility of just lifestyle modification. And as we've imaged more and more people earlier in their lives, we've been able to sort of really get a sense of, getting quite good at identifying the very early hallmarks of disease. And that's super cool.
That's so cool. I mean, this is mind-blowing because I've seen this. I told you the story of a patient I had that had non-alcoholic fatty liver disease. Actually, he was someone who was, I'm going to put in quotes, skinny fat. Like he was actually a thin guy, doesn't exercise much, eats nothing but processed foods and ultra processed foods. And he got a screening full body MRI, just, thinking, of course, cancer risk. And all of his blood tests were normal because we always combine full body MRI plus full blood and genetic screening at our clinics. And, we didn't see anything that indicated that he would have any type of liver dysfunction. And when he had his full body MRI, we found two things. One was fatty liver disease without elevation of his blood markers, and also a ton of visceral fat. He kind of hid it underneath his clothing, so we couldn't really see it. And we had a serious conversation about his lifestyle, and showed him the fatty liver disease and showed him the visceral fat. And it was a wake-up call to him, and so he would have never had this wake-up call if it wasn't for the full-body MRI, because we didn't even see it in the blood test. So the full-body MRI preceded blood test changes, which precedes symptoms and actual disease diagnosis by decades. And so I think that's an important story, and I know you have many others.
Well, I have many similar ones, to be honest. Particularly in Silicon Valley, I've had friends that come in that run triathlons.
Yeah.
I had a friend that runs an Ironman, that's his idea of like a easy day. And, he's carb loading the whole time. And he needs that for energy, but the liver's not able to process that. And it's just, and this friend of mine was pre-diabetic, didn't know about it, was the fittest person I knew in my entire life. And sometimes it's these extreme athletes that we find some of these symptoms in. Oftentimes it's also genetic predisposition. So particularly Asians or South Asians have a much higher likelihood of depositing fat in the liver or having higher visceral fat levels. And, there's a sort of like term of like the skinny fat Indian, for example.
It's very common in my culture. Very common, right?
Yeah, so they look skinny on the outside, but they're fat on the inside. That's all of that visceral fat. But it's interesting, you said the LFT, the liver function test was normal. What's both incredible and sort of problematic about our bodies is we have this tremendous plasticity.
Right. So,
we can actually be doing a lot of damage to our brain, and it may be like a decade or two before, we sort of, that reserve, the sort of like the reserve that we're having in a particular organ, sort of like we reach exhaustion, and all of a sudden now we're symptomatic. And the same is true for the liver. The liver is probably the hardest of all the organs. It puts up with a lot of abuse, from our diet, from drinking, and so on. And we're just not aware of it necessarily until you end up in a fibrotic stage, typically. So it's just great to be able to look inside and see these like very early hallmarks of these disease. Another category that I think is super fascinating is MSK degeneration in young people that we're seeing. So when we opened our first clinic in Silicon Valley, we started for the first time getting 20-year-olds in. Previously, we only operated a clinic in Canada, and the average age of our patient was in their 50s. So we got these folks in their 20s, and we were seeing a lot of particularly cervical spine degeneration. And we would show the radiologists and say, hey, what do you think? How old do you think this person is? And they might say this person is like 40 years old. So their spines were looking like they were 10, 15, sometimes 20 years older than their actual biological age. They were asymptomatic.
Wow.
And some of them were lucky. They had a congenitally wide spinal canal, and they could probably continue to have degeneration and not be symptomatic. But some of them had narrow spinal canals. And these are people that you look at their spines and you start to think, well, how are they going to be in their 50s or 60s if this sort of degeneration continues? And we both know that like mobility, once you lose mobility,
absolutely,
you stop being alive pretty quickly shortly thereafter. So the mental image I always have is, when you get off a plane and there's like 5 or 6 people with the wheelchairs waiting for folks to sort of like jump into them. When you look at the spines of these 20-year-olds, it's hard to imagine how many wheelchairs are going to be lined up next to those sort of airplanes in 20 or 30 years if we don't become aware of this and decide to do something about it now.
What do you think the reason for that is? These 20-year-olds in Silicon Valley having
We
skeletal
sit at
degeneration,
desks all the time and we're on phones the whole time.
immobility, right?
So like this posture of also looking at a phone, like our necks are not designed to hold this very heavy object on top of our shoulders at that angle.
Right.
So, we are designed for standing upright and walking around.
Yeah.
And so it's incredible how much sort of our posture has changed in the last 20, 30 years. And of course, our bodies haven't adapted to this.
Yeah.
What's happening? We're getting degeneration faster than we would have before.
Absolutely.
And we have an unpublished paper. It's really interesting where we looked at tens of thousands of our patients and we built an algorithm to estimate the age of the person. And when they first did it, and we imagined that spinal degeneration was going to be a linear process, so every year it'd get a little bit worse, and so we'd see this nice straight line. And when they first ran the model, it sort of kinked down like this at the younger ages. And the team that were working on it, they're like, well, there must be something wrong with that model or something wrong with that data. But what it was is that was the 20 or 30-year-olds that had their spines looked older than their actual biological age. And that's why it wasn't a straight line. So there was a kink. And that kink, that didn't exist anywhere else, just in sort of the 20s and 30-year-olds.
That's so interesting.
Yeah.
On that point of musculoskeletal degeneration, I know I've asked you about this before, but one of the things I've noticed in some of the scans is the amount of fat versus muscle, particularly in extremities, and you could tell like who's working out a lot. They're mostly muscle, and you could tell the people that are mostly sedentary in the amount of fatty tissue infiltration that they have into their muscle and also the amount of fat surrounding their muscles.
Yeah.
And I think I've asked you before, like at what point will we be able to get some data to give us something similar to a DEXA scan?
Yeah. So we have a whole bunch of models that are in front of the FDA right now.
That's awesome.
That will help us be able to inform patients on their the different types of fat that they're carrying on their body. So visceral fat, subcutaneous fat, liver fat, pericardial fat. Eventually, I'd also like to look at fat in muscle.
Yes. Fatty infiltration of muscle,
which is
a big risk factor, right?
Exactly. Certainly negatively correlated with longevity.
Exactly. Positively correlated metabolic disease, right?
Correct. Those models also look at all the major muscle groups. So that our patients will be able to track them over time and even look at the symmetry of muscles for people that are obviously like working out. And the third thing we're doing is measuring the volumes of all of the organs in the abdomen. And why do we do that? Well, first of all, it's kind of useful information for diagnosis. There's things that we are able to diagnose that you won't find any papers on diagnosing them with MRIs. So things like CMV, so viral infection, where we see the splenic volume changing from one scan to the next, and there's no other reason for it. But what we're finding weirdly as we sort of do these sort of biological age versus what we're observing, we're finding that obviously organ volume changes as we age, and it's something of a biomarker of how well we're aging. Right. So, for example, with the brain, on average, we lose 3% of our brain volume every 10 years of our life, from about our 30s. So it's sort of interesting to look at our brains and say, well, how are we doing? Am I losing 5%? Did I lose 5% in the last decade, or only 1%? Or did I maintain my brain volume? And it helps give a sense of how our brain, how well we are engaging in activities that are neuroprotective. Right. The same is true for prostate. It gets 3% bigger per decade. The liver gets 3% bigger per decade. So 3% seems to be the magic number. Either things are getting bigger or smaller at 3%. Yeah. And then the question is, what are you doing?
Isn't there a steeper drop off at around 65 where things get smaller, quicker? I think I read that somewhere as well. Like after the age of 65, for some reason, things just really fall off a cliff.
Yeah, well, to be fair, so the bulk of our data is between people aged 25 and 65. So we've imaged a few 100-year-olds that still seem to be in good health, but we don't have a lot of data at those extremities.
Yeah.
Yeah.
So interesting. I mean, and let's talk about the brain a little bit because we talked about diabetes. There's all the chronic diseases. Diabetes, we've talked about metabolic syndrome being part of that spectrum. We can see signs of this in the full body MRI with fatty liver infiltration, visceral fat, infiltration of the muscle with fat. We talked about musculoskeletal degeneration. That's a risk factor for all chronic disease as well. Let's talk about the other chronic diseases. Let's talk about dementia, Alzheimer's. You are doing some special data there as well.
Yeah, well, let me give you like a really natural segue, actually. So we published a paper last year that was it was the most read paper in the Journal of Aging and Disease. And it established a link between visceral fat levels and brain volume.
Wow.
So again, further evidence that our bodies are a connected system.
Yeah.
So you can't expect to walk around with a whole bunch of visceral fat and have it not affect other systems of your body.
Right.
And that was really exciting research.
Yeah.
We have a lot of collaborations on the brain side. Of course, when people come in, the first thing they ask is, do I have cancer? They're not thinking about aneurysms as much, to be honest. And then after we say, no, you don't have cancer, the next question they always ask is like, how's my brain look?
Yeah. That makes sense, right?
And historically, all we were able to do as radiologists is just say, yeah, it looks okay.
There's no cancer.
Yeah, well, no, I mean, look,
Right.
by the time we could see gross, like a radiologist would see this sort of gross
Sure.
volume loss in brain tissue, pretty much your family and friends, everyone around you would know about it
I've
first.
already noticed, right?
So we wanted to have not just us, but I think like the medical community or folks that are interested in using imaging to look at the brain wanted to get better ways of assessing sort of cognitive function or the decline thereof. And so there was a lot of interest in doing volumetric brain scans. And we've now been doing these for the last 3 years. If patients ask for them, we were able to like run them against a third-party algorithm to like calculate the volume, not just of the entire brain, but also of individual.
Like the hippocampus,
exactly.
which is responsible for memory, right?
Exactly. And obviously that's the part of the brain that we see volume loss most markedly in the case of dementia. And in fact, the average person with dementia, diagnosed with dementia, has already lost something like 30% of the volume in the hippocampus. So these techniques have the hope of being able to measure much more precisely the change in our individual brain volumes from 1 year to the next.
Mm-hmm.
So hopefully we can identify an abnormal change a lot earlier, well before that 30% decline, where, we can now hopefully make these lifestyle modifications that can make a difference.
Absolutely. I mean, prior to now, there was really, once again, Alzheimer's was a disease you just kind of, you found out when you had it and it was almost too late to do anything about it, right? And so now with the full body MRI, where you guys are able to report on hippocampal volume and brain volume, and specifically longitudinally, which means over time. And I think that's the important metric too, which is another reason to do these more than just once. I think every couple of years, like you said, is a really good idea.
There's a few caveats that are sort of not always very obvious to folks too. It can be a little bit machine dependent. Mm-hmm. So we've had folks that have come in that have had scans done in other places, and then we do a brain volume and we report that their brain volume is like 5% smaller. And that's not what someone wants to hear. No. So what's kind of great about our clinics is we've calibrated all of our machines to every other machine that we have in the network. Yep. In fact, it's a dirty secret of MRI. If you go ask a radiologist in a hospital when they're doing a reading, and they'll be able to tell you exactly which MRI machine in the facility the images came off. Oh, wow. Because they're all completely unique. They have unique signals.
So interesting.
But our radiologists can't tell.
That's powerful.
So, and that's really important for these very sensitive. I mean, here, imagine like the hippocampus is not a big part of the brain.
Like you said, you're doing like 1 millimeter.
So we're doing these little 1
voxels,
So if you're off by a few voxels, that can be a 5% reduction in
Right.
volume. So like that precision is actually really, really important.
Right.
Then we have some internal models that we are running. We do these for research. So I want to be clear, they're not FDA cleared, they're not offered to consumers, but really it's our own research in trying to find other biomarkers. So there we have models that measure the cortical thickness. So these are the sort of folds that are on the outside of the brain. They're the furthest from the brain, the blood supply. So they're parts of the brain that lose blood supply faster and can atrophy earlier than sort of the earliest parts that sort of atrophy. And then there's a new sequence. I actually just tried it myself last week, which is it measures perfusion. And we have some collaborators here. I mean, we're going to offer something in the new year that's sort of a neuro package that sort of does some of the cutting edge sequences that enable us to really sort of like peel back the clock.
Wow, that's incredible. Yeah, I know Dr. Daniel Amen does a lot of perfusion sequences using a radiolabeled. Is a radiolabeled dye with
And
the
a SPECT
gallium,
scanner.
the SPECT
Yeah.
scanner, right?
Yeah.
Exactly. So to be able to get some level of precision from an MRI of perfusion abnormalities could be a game changer as well.
Yeah, no, we think that this probably will be better than SPEC as a modality, and we'll eventually be able to report quantitatively perfusion, which means then it's not just eyeballing two pictures from one year to the next, but you can get a score.
Oh,
Yeah.
That's exciting. That is really exciting. Okay, moving on from the brain, let's talk about the next big organ that we all worry about is our heart.
Uh-huh.
And when you're scanning a body, you tell people not to move, but they can't stop moving their heart.
Exactly.
So the heart is moving, and you're imaging it while it's in motion, and that presents challenges. However, there's lots of diagnostic potential for the heart, especially related to cardiovascular disease. So what are you doing currently, and where is the technology going with cardiovascular imaging?
Yeah, so currently we're not that great for the heart, if I'm being totally honest. We can get a sense of cardiovascular disease by looking sort of anecdotally at the rest of the body. So if a heart is a pump, so if it's not doing a good job as a pump, we will start to see fluid accumulating in the lungs and the lower extremities. So if we see abnormal amounts of fluid there, we almost always know that there's a pump problem and you should go get another test.
Correct.
We don't see the coronary arteries. So we can't really assess someone directly for heart attack risk. However, the atherosclerotic process that deposits, that sort of like blocks those arteries also block other small capillaries in the body. And we are able to see that in the brain most easily because dead brain tissue, so brain tissue that's sort of is dead because it didn't get blood, shows up as a white matter lesion. And so all of us have a few of these in our brains. I've got 3. Turns out we don't know why they're there, but getting 1 per decade of your life is fine. But if we see sort of a confluence of these, or we see a condition called small vessel ischemia, it sort of points to something going on in the plumbing.
Got it.
And sort of one possibility is cardiovascular disease.
Got it.
So that's where we're at today. We're also launching in the new year a new sequence that looks at myocardial strain. So here it's a sequence that looks at the actual elasticity of the heart itself, so the heart wall. And the theory here is that if you have compromised supply of blood to the heart, what happens is the heart loses its elasticity. It becomes stiff. And this sequence is sensitive to measuring that sort of amount of stiffness in the heart wall. And so we create a map, and we can sort of see which parts of the heart are stiffer than they otherwise should be, and we can create sort of a score, almost like a screening score that would help us identify ideally patients that then should go and get a dedicated heart study. Yeah.
That just blows my mind that we'll have some sort of score that tells us whether you need a cardiovascular imaging further from the full body MRI. I think that will also be another game changer.
And we'll see how, there's not a lot of established guidelines around this. So I imagine what my radiologist would say would be, hey, if you have a strong family history or you have, you're symptomatic, you should be anyhow getting sort of advice from a cardiologist or doing a CT angiogram or calcium score or things like this.
Right.
But for patients that have normal risk profile or are younger, this might be a way to screen them. And also over time, those scores might help give us some insight into how our cardiovascular system is tracking as we age.
Yeah.
Yeah.
Yeah, I think just like cancer, there's an analogy here. The MRI is good for a lot of things. There's certain blind spots. One of them could be coronary vessel blockages. We get a calcium score on all of our patients that are over the age of 40 as a screening modality. And I think it's useful to have this even younger kind of indication, but we don't have anything, and we just don't recommend it because there is radiation involved, even though it's a very small amount for our younger patients with no risk factors. So this will be a great score for us to have because we do recommend the full body MRI even for younger patients. And I think that's useful for us as far as an indicator for how aggressive we need to be in cardiovascular imaging.
Well, and I think something like 1 in every 3 people that have a heart attack don't have any known risk factors for heart attack.
Right.
So I think these types of tests, whether it's a calcium score or maybe these new strain analysis that we're looking to launch, the goal here is, can we identify non-obvious insight to our patients that come in? And I remember I had a friend of mine who was a policeman, super fit, looks 20 years younger than he is, and he came in for a scan and he said, well, what else should I do? I said, well, go get a calcium score, because you never know. And he got a calcium score and he was off the charts. And you wouldn't know it if you looked at him or if he looked in the mirror. So what I love about these tests that are available to us these days is, it's not the obvious stuff that you would know if you looked in the mirror. I mean, if you're massively overweight or you have high blood pressure or things like that, you're going to have problems.
Yeah.
It's what you don't know about that your lifestyle doesn't necessarily, inform you on.
Exactly.
Yeah.
Yeah. Looking under the hood, like you had mentioned, your friend who runs triathlons or marathons. We have a lot of patients here at my clinic that are professional athletes. And I mean, they look like perfect specimens of humans.
Yeah.
But when you look under the hood, they have metabolic disease, they have inflammation, they have all sorts of issues. So I think it's important to not just, look, we live in 2024, 2025 coming up here pretty soon. These technologies are available and they're getting more ubiquitous and they're getting cheaper. And if you can do something and your pocketbook can afford it, I think it's not just a suggestion. I think it's almost necessary now because without your health, you have nothing. The quote is the person who has, what's the quote again? The person who has everything wants one thing, or what's that quote? The person.
You're gonna stump me. No.
Yeah, I'm stumped on it too. I can't remember. Anyway, the point being is that until you lose your health, you wish you spent all your money on looking at your health under the hood, really. And so I think that if it's affordable, I think it's important to do these things. And if it's not, just wait a few more years. These things are going to get less and less expensive as time goes on, right?
Yeah, and also just go back to the psychology of it to some extent.
Yeah.
I think we're really good at convincing ourselves that we don't need something today.
Yes, true.
The best an example everyone can relate to pretty much is going to the dentist.
Yes.
We're supposed to go every 6 months. How many of us go every 6 months?
Right.
And I don't feel any pain. I'm busy. I can put it off another week. And I think that's probably like the biggest problem with preventive health is like you can always put it off for another day.
Right.
And particularly for a test like what we do, but any comprehensive blood when you haven't done them for years, it can be a little bit more scary to sort of figure out, to see the accumulation of sort of all of our lifestyle choices for the last 5 or 10 years. I traveled and lived over in Europe at one point, and I hadn't been a dentist for 5 years, and I was dreading the day I was going.
Absolutely.
And why did I dread it? Because, the chance of needing a root canal was way higher than if I had only been like 6 months before.
Exactly.
And these, our test is the same. Like the first one is the scariest, but sort of like the most anxiety inducing, I guess. But for patients that are doing this every year, it's sort of like a way to sort of like outsource the stuff that are not in your control to us or to Next Health when it comes to blood tests, and spend more time just sort of living their lives rather than worrying about what would be under the skin.
Yeah, absolutely. I remember the quote you reminded me. The person who has their health wants 1,000 things. The person who doesn't have their health only wants one thing.
Yeah.
So you don't want to wait until it's too late before you find out what's really going on under the hood.
Yeah.
Last topic I kind of want to cover with you is, I was trained in Western medicine, and a lot of Western medicine doctors, I think, would not just negate the idea of full body MRI, but also be actively against it, And I think you've told me that you've hit up, you've talked to patients that have hit up against a wall with their doctor that's telling them absolutely do not do this, right? But I do think perceptions are changing. And you told me that you just recently came back from a conference and you talk to a lot of radiologists all the time. And I'd like to get your kind of perspective on where kind of the group think is going on something like full body MRI.
Yeah, so I just came back. I flew back to LA today from the big annual radiology conference in Chicago, and I've been going for the last 4 years. And we have a booth there, and we use it to.
Did you wear protection, like full body armor, when you go to these things?
It's I would say in the early days it was pretty gnarly. We had a lot of folks come up and wanting to argue with us about why are we doing this. Where's the evidence? Come up with a lot of anecdotal sort of like contradictions. And I would say like the most interesting observation from having just come back from the last conference, so 4 years later, is just how much more open the Society of Radiologists are to thinking about how these scans might play a part in people's health. Now, I don't want to oversell. It's not like they're all jumping out of their seats. But we've gone from folks sort of like actively discouraging to being sort of a lot more neutral about this and saying, well, this is, if a patient understands that they're going to learn a lot about their health here and they feel like they can handle it and they have a good primary care provider, and you want to do it, it's up to you. And I think that's like been a big step actually in 4 years, to be honest. And then we go out every day meeting with physicians, specialists, oncology professionals. We invite them in to come and explore what we're doing. We have them speak with our radiologists. So we spend a lot of money and time essentially helping educate folks on just where this field has gone to. And a lot more people are open to it. But at the end of the day, just to go back to what we're talking about, anxiety or our own feelings, doctors are humans too. And they've been more exposed to sort of late stage disease and all of the scary stuff than maybe the average consumer has. And the average physician's health, the average physician that we screen, their health is not better than the average consumer, and oftentimes it's worse. Mm-hmm. And they have exactly the same fears about knowing about what's going on inside. Yeah. And they have, and additionally, they can point to a lot of studies that might have been on CT or other modalities or different forms of MRI, and feel good about not doing it themselves. Mm-hmm. And I would just, if you're an individual and you're interested in this and you're going to speak to your physician about it, I would, also ask a bunch of questions and really understand what the basis might be for any reluctance that they might have.
Right.
And is it rooted in their own fears?
Right. No, that's a great point. It's true. I was a very sick doctor myself for many years, and I trained in Western medicine at the Mayo Clinic, and I thought I knew everything about how to remain healthy, but in reality, you just learn about how to diagnose disease and treat disease. And so this is a whole new world, even for Western medicine. So with that, I wanted to thank you for everything that, first of all, coming on my podcast and talking about this, but also everything you're doing for the world. I think this is a game-changing technology, and you are really at the tip of the spear of really changing not just people's access to this technology, but also the mindset, and also bringing the technology forward. I think it's fantastic what Prenuvo has done and it continues to do. So thank you very much, Andrew, for joining me today.
I appreciate it. Thanks for having me, Darshan.
Yeah. How can people find out more about you, Prenuvo, and where are you located right now and where are you going?
Yeah, so we're currently in 17 locations in the US, and we're opening up a new location every month. So depending on when this airs, there might be 1 or 2 more that are open. So I'd encourage people to go to the website and search for a location that's close to them. Next year, we'll also be opening internationally in London and Australia, where I'm from. And beyond that, we hope to be in more and more countries and more locations inside the US as well. And I believe we put together a discount for your listeners too.
Oh, thank you.
I don't know if you want to put that in the notes to
Absolutely.
the podcast.
Well, how do they access it? Is it a discount code online?
Yeah, they go to prenuvo.com extend.
Prenuvo.com/extend. Prenuvo.com/extend. Thank you for doing that. Okay.
So that will give folks a discount off the comprehensive whole body scan and hopefully make it a little bit easier for people to come in.
Oh, I love that. Thank you very much. And we offer the Prenuvo scan as part of what we offer in Next Health of our comprehensive screening package, which includes your scan. It also includes, if indicated, heart scan and full biomarker testing and genetic screening as well. So we really try to tie all the modalities together. And I'm excited because I think we're opening a few locations together as well. So that's going to be exciting news for both of us as we move forward in this new world.
Yeah, well, I think I'm really excited about sort of obviously the work that you guys are doing, but just like the tremendous activity around preventive health post-COVID. Right. And it's interesting, we get a lot of folks coming to our clinics and they don't have anyone that they even think of as their primary care provider. And when you start to think about preventive health rather than reactive health, actually the role of the physician becomes more and more important. So I'm excited for being a part of that ecosystem. And I think we're a pretty important and relevant solution for a lot of folks, but there's lots of other really interesting innovations happening as well, many of which you guys are pioneering.
Well, thank you so much. Thank you so much for joining me today. And I can't wait to have you on again, where we can talk about what you've advanced and how you're going for the next few years.
Maybe we go through a scan of your brain next time.
Let's do it. I would love that.
Awesome. Thanks for having me.
Thank you, Andrew.
Bye-bye.